Hello, I'd like to reflect on how we take an ethical approach to making decisions over complex patients. I'm going to use the example of a patient with hip fracture. We see many patients, 70,000 people in the UK, presenting with this, which is the commonest reason for somebody who's frail, old, complex, medically challenging to need emergency anaesthesia and surgery. So there's an urgency about making decisions for her. And it is tempting to make decisions for her in her best interests. And as a rule of thumb, I always question my motivation and my approach when I find myself having introduced the word best interests into patient care. I think it's a superficial expression which has some gaps in it and potentially can lead to difficulties and inappropriate decision making. But I do have a duty to do what will benefit my patient. Or the duties of a doctor is to do that which will benefit their patient. We also have a duty to do no harm, and it's very easy to think that best interests are the balance between these two considerations, that a patient's best interests are served by doing something that will benefit them if we can avoid doing them in harm. But that's not how we should be thinking about these. These principles are more sophisticated than that. The duty to do what will benefit a patient, beneficence, and maleficence, the duty not to do harm, are just two of the ethical principles that are fundamental to our roles as doctors. When we're therefore making decisions with the patient around the operation and anaesthetic that they need for their hip fracture, we need to be thinking about those principles. We need to be providing the patient with enough information so that they can understand the benefits and the risks of surgery. And that's often done well. It can be done extremely poorly. It's very easy to, if you look at consent forms, to see that the vast majority of patients are consented for the possibility of infection or bleeding, which are very rare. Less than 1% of patients will get that. Very few patients are consented for the very likely development of delirium, a far more alarming concern that arises in perhaps a third of all the patients following hip fracture surgery. So the provision of information is important. And this isn't about a discussion of should you have this operation or that operation. You can go to the literature and argue at great length about the subtle benefits in statistical terms of a total hip replacement over a hemiarthroplasty for some patients with hip fracture. You can argue at length and broadly unsuccessfully that one form of anaesthetic is better than another. But these are really quite complex arguments and not really something that patients should be worried about. In general, patients have a fairly clear idea of which sort of anaesthetic they'd prefer, and anaesthetists are broadly happy to accept that. But there are situations when one sort of anaesthetic might not be suitable. I do, however, keep bumping up against patients who've had a really quite challenging decision-making process over whether they should have a total hip replacement or a hemiarthroplasty. And really, that's a decision that is terribly complex to explain to an individual patient. What's more important, perhaps, is that they should have had the pros and cons of not having an operation put to them. Not to worry about which bit of metalwork you have put in, but whether you have surgery at all. And to understand the benefits of surgery needs the potential risks of not having surgery put to people. Chances of people dying in the perioperative period in the UK are now very low. We lose perhaps 1% of our most complex patients in the 48 hours around surgery. But the chances of people suffering poor outcomes and dying if they don't have surgery are substantially higher than that. So the decision over whether somebody has surgery should be something that's put to them and part of a conversation. But the extent of variation between different hospitals in the UK in the rates of patients having surgery or not having surgery is enormous. And this clearly can't be a manifestation of patient choice in different hospitals. This has to reflect different approaches to the presentation of information and decision-making process from the clinical team looking after them. And that does need to be questioned. And it has to be true that the approach to taking consent can be extremely lax in some settings. This I found some years ago by the bed of a very deaf patient, and clearly they'd not had an opportunity to make any decision about their operation. They'd not been supported to get over their sensory impairment. This had been a fairly cavalier approach. That sounds and is a very rare event, but at the same time, while we should be presenting all the information that patients need, with the leaflets to explain, videos to explain, these are all boxes that can be ticked on the consent form, showing that you've been able to provide patients with the information that they need to make a full and informed decision. Within the UK, we found that only a quarter of hospitals make provision for patients to receive such information in their own language. And this is a resource that the QR code can take you to, which has the top 10 languages spoken by people for whom English is not the first language in the UK, a population of about 3 million people. So this is a resource that you can use, download, and print your own information sheets for patients and their families to inform the decision-making process. Because our duty, our third ethical duty as doctors, is to support patients to make decisions about their own care. I'm not going to talk, because it would be a prolonged and complex talk about capacity assessment, but respect for autonomy does require that the patients are given the opportunity to understand, to read, to work through the information necessary for them to make the decision about surgery or not surgery, and what's going to happen to them. And discussion of whether somebody is competent to make that decision can only happen in the light of the way in which they engage in, understand, follow, and respond to that conversation. It's not about making assessments of the severity of cognitive impairment or psychiatric conditions. It's about their ability to engage with the discussion of the question in front of them, which is surgery for their hip fracture. So consent form 1 may not be the most appropriate thing to be using. Consent form 4 is a very sophisticated structure that takes you through the full gamut of ethical principles that are necessary to this sort of decision. So it takes you through the issues of beneficence, non-maleficence, guides you through documenting and understanding why somebody may lack capacity in that. But it also presents the fourth ethical principle. There are only four, but the fourth ethical principle that we have to respect as doctors, and that's a duty to consider the implications for other patients. That's called justice. Consent form 4 pushes you to involve other people in the decision-making process if somebody lacks capacity or might lack capacity. And that's important because the decision for somebody to have surgery, potentially a life-threatening procedure, has implications for their family. The possibility they might die or suffer a complication as a result of surgery is something that the family will be profoundly affected by. Just as they might be affected by the need to look after this person after surgery has or hasn't gone ahead, and to deal with them as carers in the longer term. So thinking about other patients and thinking about other people as potentially patients themselves is something that justice reminds us to do. The other aspect of justice is, of course, the balloon debate that is the morning X-ray meeting, where the potential candidates for surgery today are all looked at together and decisions made as to which patient has the greatest need for surgery today. And for this reason, I think best interest remains a complex concept to talk about. And just talking about decisions as being in a patient's best interest, put aside the fact that you also have a responsibility to other patients' best interests. So I don't like the expression best interest. I do think we should be thinking about the 4 ethical principles for every situation in which you feel uncomfortable. And many of the other decisions that we'll have to make during a patient's time in hospital recovering from a hip fracture can be much more challenging. And the most typically difficult and emotionally challenging decision that we end up is somebody who's made an incomplete recovery, both either mentally or physically, and the question arises of whether it's right for her to go home, whether it's appropriate for her to go home. And again, the question of the benefits of being at home to her, the risks of being at home to her, the the extent to which she is able and supported to make an informed decision about those benefits and risks, and the implications for other people, for staff, family, carers who might be involved in dealing with her, looking after her, or dealing with the consequences if something went wrong after she'd gone home. Those four ethical principles will come in, and I think we're often tempted to try and argue these through in a best interest meeting where the team talk about the patient in the patient's absence because the patient's capacity is questioned. But that's not how things should work. If you're faced with a complex decision like this and you don't know what to do about it, if you're faced with any situation in which you're being asked to make a decision that you don't feel fully comfortable with, I would just flip back to consent form 4. We can do dramatic surgical procedures for people on the basis of consent form 4. And consent form 4 is a very nice structured reminder of some of the principles that you need to be thinking about when you're making any decision that you feel uncomfortable about. If you're able to flick through it, you don't need to fill it in when you're asking and making decisions about discharge from hospital. But just flicking through it, it will remind you of the possibilities that you might be needing to involve other people, other agencies in your process. And respect for the four ethical principles is really quite well defined in this, and it's a very useful handbook that's always available on ward for junior doctors who are being asked to make complex decisions. Thank you.